Okay.
You ready?
Yes.
Okay. So my name is Tanya Howard. I'm from the Regional Clinical Performance Committee, and this is webinar number 1 of a series of 4 different webinars talking about reducing non-urgent ED utilization and the best practices of care. Today we have Jennifer, a physician from UVM Family Medicine, and we also have Schwartz, whose recording will actually be in a separate recording, but will be available as co-chairs of the RCP ED Utilization Group are myself, Tanya Howard, nurse practitioner from Health Centers of Burlington, also Rick Dooley, a PA from the Thomas Health Center, a member of Health First. So the series of webinars, we are looking at reducing utilization and the best practices for care. Our first webinar, which is this webinar, is discussing UTI and acute GI illnesses to avoid the ER on November 9th. We also had a webinar on addressing pediatric issues, and that recording will also be available. On December 7th, we will have Dr. Michael LaMantia, who's a geriatric specialist, talking about addressing geriatric issues. In January, we will be talking about just some practical office strategies and the nurse triage. Activated. Okay. If you did request CME, the registration and evaluation should be available within the link or close to the link for the recorded webinar. If you do have any questions about the CME, you can email Laura Remick at the Northeastern Vermont AHEC organization.
Excellent.
So just as some background, Chittenden County Regional Clinical Performance Committee is a team of cross-organizational members. It's been working collaboratively for a couple of years now to improve the health outcomes in our region. You can see on this list the different organizations that are involved in the RCPC. One of the work groups of the RCPC is looking at reducing ED utilization. As you can see from the slide, there has been a definite increase in ED outpatient visits over the last couple of years. And based on the data from the emergency room, in 2015, 1,258 of those visits were for 4 very common viral or infectious illnesses: nausea, vomiting, diarrhea, cough, and URI, and UTI. We found that the GI complaints made up 918 of those, and UTI made up 75 of those visits. So over half of those visits, or almost half of those visits, were from UTI and GI symptoms. Currently, there are several ongoing projects that are happening with other groups that are looking at things like chronic care management and avoiding ED utilization, as well as mental health projects. The Vermont Nurses Association is also doing a lot of work. And we found that looking at these acute illnesses could be possibly avoidable, and wanted to focus our efforts on these particular illnesses and looking at the primary care practice as a place to start in reducing those visits. So now we have Dr. Jennifer Bamford from UVM Family Medicine, who is going to be presenting on UTI.
So my name is Dr. Jennifer Bamford, and I'm going to talk about effective and efficient ambulatory UTI management. As we just heard, this is something that's frequently seen in the ER, and simple UTIs should not be seen in the ER. The objectives for this talk are to select patients that are appropriate for home self-management or telephone management of UTI. These are ways that you can keep the patients both out of your office and out of other venues. To implement a protocol for phone triage of patients presenting with UTI symptoms, and to update you on some of the latest evidence about treating uncomplicated UTI that you may not know. Why do we care? We care because we see UTIs every day, and the women are usually fairly distressed about it because they're painful. It's extremely common and very, very expensive. There are about 150 million episodes of UTI a year. It costs about $6 billion. The majority of this is uncomplicated cystitis in women. This disease also accounts for about 1/4 of all antibiotics prescribed in general practice. With efficient triage and treatment protocols, we should be able to treat more of these patients over the phone. We found that this has improved patient care, patient satisfaction, and can improve overall cost to the healthcare system. A large proportion of treatment for UTI has been for asymptomatic bacteriuria, and by not treating this condition at all, we can greatly impact the amount of unnecessary antibiotics prescribed. So, what is uncomplicated cystitis? Uncomplicated cystitis is a simple UTI. This is generally thought of as symptoms plus bacteriuria and inflammation in a healthy adult female without urinary tract abnormalities. And the symptoms are those that we hear every day: burning when you urinate, frequency, urgency to go, scant urine per episode of voiding, sometimes blood in the urine, sometimes an odor, and cloudy urine. So that's a uncomplicated UTI. So what constitutes a complicated problem? And this would be when you're looking for signs of an alternative diagnosis. Fever, obviously that brings you to think of systemic problems such as pyelonephritis or urosepsis. Flank pain and hematuria would make you think more of kidney stones. Diabetes makes everything more complicated and more likely to have systemic disease. Immunosuppression does the same thing. Anyone with abnormal urinary tract anatomy is at much higher risk. Patients who have an indwelling catheter. Pregnant women are not in the category of simple UTIs. Males never are. Urologic surgery recently is a risk factor for more complicated disease, and then any concern for sexually transmitted infections. The presence of all of these items indicates the need for further evaluation and workup, and they are no longer simple. So, newer concepts in urine and urinary tract treatment. These are some important concepts that can contradict previous thinking, and were not necessarily the way most of us were taught. So the first important concept is that urine is not sterile. Years ago, we told people that there's nothing in the urine. If there's bacteria there, we need to treat it. This is clearly not true anymore. We have a microbiome of the urinary tract. We've found intracellular bacteria, bacteria that'll grow under different conditions than what we usually use with the agar plates in practice now. And there's also viruses that live in our bladders. These organisms are there all the time, and some of them are protective against the more virulent disease-causing organisms. The presence of these bugs were found with gene sequencing and then confirmed using different culture methods. Every course of antibiotics you have will affect this microbiome, and it's not just in your urine, it's everywhere else in your body. And it can take your microbiome a full year to recover from just one course of antibiotics. The next important concept is that asymptomatic bacteriuria is not an infection. Many times providers, whether it would be in the office or at the emergency room, will get a urine when the patient doesn't really have urinary symptoms. It will be positive, and then we'll treat because we feel we have to treat. But asymptomatic bacteriuria is not an infection. This is when the patient has absolutely no urinary symptoms but does have a significant load of bacteria in the urine. This does not lead to more severe urinary tract disease. They have done studies on young women, old women living at home, old women living in nursing care facilities, and diabetic women, found the woman who had asymptomatic bacteriuria, treated some, didn't treat the others, and there was no difference at all in either group. So this is not something that leads to more serious disease. At least 50% of nursing home residents have this. The condition does not cause agitation. It does not cause mental status change. Although the nurses will call you all the time to try to get a urine for this, try not to do it. Antibiotics are not going to decrease the delirium. The people that this is not true for would be pregnant women where there is good evidence to treat, and then patients who are going to get a urologic procedure that breaks the mucosal barrier. So the next concept is that your simple UTI is going to turn into pyelonephritis if you don't treat it. This also is untrue. Usually people with simple UTI just get better, whether you treat them or not. 2/3 of these infections will go away without any antibiotics on their own. There was a study that looked at a placebo versus an antibiotic group. In the placebo group, only 5 out of 234 people developed pyelonephritis, and the antibiotic group, 1 out of 234 developed pyelo, and this number wasn't statistically significant. So there's no great evidence that using antibiotics can even prevent the development of pyelo. And interestingly enough, pyelonephritis and urosepsis patients, most of them never had symptoms of dysuria, frequency, or urgency anyway. So the next concept is, why do you treat UTI? Well, you treat it for symptom relief. You're not doing it to sterilize the urine. And symptom relief can be done with agents that aren't antibiotics. Looking at this, there were several different trials. There were 5 placebo-controlled trials, randomized antibiotic to placebo, and the symptoms did decrease a little faster in the antibiotic group, and the bacteriuria cleared a little faster in the antibiotic group, but both groups got better. There was also a couple of trials, one of them fairly large, that looked at ibuprofen to antibiotics. 2/3 of the ibuprofen group improved without antibiotics. And this is a reason why you can use delayed prescribing. So use the ibuprofen first if the patient has mild to moderate symptoms, and then use the antibiotic if they're not improving on that. I wouldn't do this for people with really severe symptoms. Only 1/3 of these patients required antibiotics for the next 9 weeks, whereas in the antibiotic group, 20% of patients required a different antibiotic in the next 9 weeks. So you're looking at 33% to 20%, so not such a huge difference, but a lot of decrease in antibiotic use. And then finally, this is not a new concept, but it's something that can be easily forgotten, is antibiotics are harmful. They can cause side effects, make patients feel terrible when they could have gotten better on their own. And it definitely increases the risk for resistant infections, as well as increasing the risk for future infections, probably by disrupting the microbiome. There was a study done that looked at people who have frequent infections. So this group was 700 women, and they had 2 or more UTIs in the previous year and none in the past month. These women were put into 2 groups, one to be treated with antibiotics every infection they had, and one to use something else, but not antibiotics. And by the end of the year, the group that was untreated had fewer infections overall than the treated group. This is not what we would normally think. There is harm due to resistant infections. This is my plug for good antibiotic stewardship. The old data that we have in 1995, the U.S. Office of Technology Assessment Report estimated that there was a cost of $1.3 billion, 1992 dollars, a year for just 6 species of antibiotic-resistant infections in the U.S. alone. I'm sure that number is much higher now, considering that's 20 years old. In 2013, the CDC reported that at least 2 million people a year will acquire serious bacterial infections with resistant organisms, and 23,000 people die annually from this. The scary estimate is that if nothing is done to prevent our problem of resistance, by 2030, these organisms will have killed 100 million people. And in 2010 to 2011, the CDC estimated that we doctors prescribed 262 million prescriptions for antibiotics, and at least 30% of these were unnecessary. This protocol was put in, all right, the barriers to change. Change is hard for any of you who've tried to implement it. We have decades of current practice. Patients are used to needing to have their antibiotic, and providers are used to needing to give it to them. It's very difficult to change someone's opinion when for 20 years they've been treated one way and you want to change the treatment plan. It will take much longer to explain to a patient why an antibiotic is not necessary and why it may be harmful to them than it does to give an antibiotic. I know I can write for the antibiotic in about 20 seconds, send it to their pharmacy, but for me to take the time to explain, why I want to do this and why the antibiotic may be harmful and what else can be done when they're sitting there having to run to the bathroom every 10 minutes is a difficult thing to do. UTIs are extremely uncomfortable for many women, and this is the best reason to treat. Antibiotics do work, and they work a little bit faster, although not always needed. So, alternate ways to treat uncomplicated UTI that don't require a visit. So this is ways and techniques that you can use in your office to try to take care of all your patients, make them feel better without having to see them or send them to urgent care or the ER. One way is to do a telephone protocol, and UVM has a nice protocol that we use through our triage nursing staff. I'm going to go over that in a few minutes. Another way is to give the patient with chronic UTIs, recurrent UTIs, to have at home and for antibiotics with refills on it, and then instructions on when to use it and when not to use it, and when to follow up and when to be seen. And then finally, you can certainly use antibiotics, a one-time use an hour after sex for the unfortunate woman who happens to get a UTI every time she has sexual intercourse. This doesn't do much for a couple. All of these items can decrease the cost of diagnosis, decrease the number of physician visits, decrease the number of days the patient is miserable compared to physician-initiated treatment, which takes time to get in, be seen, get the drugs. Also can decrease antibiotic exposure, especially if you're taking those women who you used to have on prophylaxis. There are a lot of women out there who've been on antibiotics for years to prevent their UTIs. We do know that antibiotic prophylaxis works, but it does increase resistance. And some of those studies show that, maybe they'd get fewer UTIs if they didn't have the antibiotic on board at all. So, UVM's telephone protocol. This protocol was put into place in November of 2013, and it's due to be reviewed just about now. I'm sure I will be on that committee in some form or fashion. This was designed to give our RN team a guideline for phone evaluation, triage, and care plans for those with UTI symptoms. This is to avoid the doctor's visit if we can, also keep them out of the ER or the urgent care. So what will happen is the patient phones in with symptoms. The nurse will assess their risk factors. They look at how likely is this a UTI based on classic symptoms, and what were those signs and symptoms of complicated UTI or other cause for symptoms, and then the duration of these symptoms. Any patient who has risk factors on that list, age less than 18, greater than 65, or duration greater than 7 days, or their very first episode of symptoms are going to be offered an appointment, maximum within a day. For those women who are age 18 to 65, have UTI symptoms, have a previous history of UTI, have no risk factors, then the nurse can actually just complete an order for antibiotics for that patient. Our current protocol has 4 drugs that can be used: sulfamethoxazole trimethoprim DS BID for 3 days, nitrofurantoin 100 milligrams BID for 5 days, cephalexin 500 milligrams BID for 5 days, and ciprofloxacin 250 milligrams BID for 3 days. The nurses are supposed to go down the list in that order, cross-check for allergies and drugs used for previous UTIs, and then take a medication, send it to their pharmacy. All of this is documented into the chart and then sent to the physician to sign off. The patient avoids a visit and gets relief, and all patients are instructed to call back if not improving within 24 hours. So changes, like I said, it's about to be revamped, so I think the protocol works and it's been helpful, but based on some of the newer data, there's certainly some things I might change about this. This is not the current protocol, but maybe in the future. One option would be to offer the women ibuprofen 400 milligrams every 6 hours for discomfort, increase the fluids, have them call back if they're not improving or worsening, and then give them antibiotics then. If they decline this method, that would still be fine for the nurses to give them antibiotics, but there is the need to educate patients on how this is now considered an acceptable method for treatment for women with mild to moderate symptoms. It's also important to educate patients on the potential harms of antibiotics. And then another consideration would be to give phenazopyridine prescription, or tell them about the over-the-counter versions of this, such as Azo or Urostat. A final thing that I probably would change would be to take ciprofloxacin off of this list entirely, unless really a last resort, because of the new side effect profile of that drug, which is thought to be much more severe than previous. So, based on all this new knowledge, I have a couple of questions to see about who's appropriate. Which of the following patients is appropriate for phone management of UTI? A, 40-year-old male with dysuria for 3 days and a new sex partner. B, a 53-year-old female with uncontrolled diabetes complaining of dysuria for 8 days. C, a 32-year-old female with past medical history of mild intermittent asthma and 2 days of dysuria and history of previous UTI. Or D, a 24-year-old female with hematuria, fever, and flank pain. The answer, of course, is C. There's the only simple one there. And number 2, which of the following therapies are appropriate for treatment of uncomplicated cystitis? Sulfamethoxazole trimethoprim DS BID for 3 days. B, ibuprofen 400 milligrams Q6 PRN. C, increased fluids, try phenazopyridine 200 milligrams TID for 2 days, or all of the above. And the answer is D, all of the above. So in conclusion, we are at the beginning of a potentially large shift in the way that we can manage uncomplicated cystitis. It is difficult and slow to get patients and healthcare workers to believe that the antibiotics are not always necessary, and we need to just try to do what's best for the patient and never forget that antibiotics can cause harm. So hopefully you can use some of this information, keep some of your patients out of the ER, and improve your antibiotic usage. Thank you.
Thank you, Jennifer. And we will have a separate recording with Dr. Schwartz. And if you can look for that link, and also the link to the CME paperwork. Thank you.
I'm David Schwartz, I'm a gastroenterologist, and Rick Dooley asked if I would put together a brief discussion on outpatient management of acute gastroenteritis. He'd previously given a talk commenting how expensive it was for patients to present to an emergency room for an illness that could be managed as an outpatient. The following is my presentation. I thought the first question we should ask is, what are the indications that require a trip to the emergency room for gastroenteritis with dehydration? Well, if a patient has hematochezia and bloody diarrhea, you would think of an enteroinvasive organism or inflammatory bowel disease, and that should be sent to the emergency room. If there's severe abdominal pain, that should prompt a trip to the emergency room. If it's more of a chronic issue with associated weight loss, the evaluation should be performed in the emergency room. If the individual has a risk for C. diff diarrhea, such as recent antibiotics, recent attack of C. diff, or chemotherapy, which increases the risk for C. diff, they should be sent to the emergency room. Generally speaking, the individual over the age of 65 should not be managed in the office if they're immunocompromised or if they're pregnant. The causes of viral gastroenteritis are neurovirus, such as the cruise ship outbreak we all heard of a few years ago, rotavirus, enteric adenovirus, and astrovirus. Rotavirus accounts for up to 25% of acute community cases. These viral illnesses are spread from contaminated foods and water and via a person-to-person spread. In the pediatric world, 70% of gastroenteritis is caused by viruses. In adults, there can be bacteria or parasites as well, but in the PD population, it's mostly viruses. There are, I believe, polymerase chain reaction-based studies to assess for norovirus and rotavirus. I don't know how commonly they are used, though. In terms of the epidemiology of gastroenteritis, in the United States, this is a cause of 300 pediatric deaths each year. It represents 1.5 million annual visits to primary care providers. It leads to 220,000 hospital admissions for children under 5, which represents 10% of all admissions for children in the United States. So in the pediatric population, it's quite common. How do we make the diagnosis? Well, clinically, patients present with a history of a rapid onset of a diarrheal illness characterized by at least 3 stools a day. The incubation period is roughly 1 to 3 days. 1 to 3 days. Associated symptoms can be nausea, vomiting, fever, mild abdominal pain, unlike the severe pain, which should prompt an ER visit. The abdominal discomfort is mild and diffuse. It doesn't localize to left lower quadrant, right lower quadrant. You'd think of other illnesses if that were the case. There is really no role looking for fecal lactoferrin or calprotectin, which are markers for white blood cells. No role for looking for C. diff, Salmonella, Shigella, enteroinvasive organisms, unless there's bloody diarrhea or chronicity or persistent fever. The mainstay of therapy is oral rehydration therapy. It's been studied extensively, and it's quite simple to make at home or in your office. You take sodium chloride, table salt, 3.5 grams. You mix it with 20 grams of glucose. You add 2.5 grams of baking soda, and then some potassium chloride, 1.5 grams. You mix in a liter of water. As an aside, I purchased some online for myself before an endurance athletic event to prevent dehydration, and very inexpensive. You take a packet, you mix it in a liter of water. It has a brackish taste to it. It's kind of a salty taste, but it's very effective. If you wanted to make an even simpler solution without the potassium, you take 6 teaspoons of sugar and a half teaspoon of salt, and you put that in 1 liter of water. You ask the individual to drink up to 2 times the estimated amount of deficit. I think that's going to be difficult for your patients to give you a sense of their deficit because they're not measuring their volume of stool. I would have them just drink it until they feel rehydrated, skin turgor, dry mouth, usual clinical assessment of hydration status. The World Health Organization touts this as being extremely important. Cholera around the world is a leading cause of death in pediatric population, and this oral rehydration solutions have really decrease markedly the incidence of death in third world nations. They recommend you drink 250 cc's every 15 minutes until you're not lightheaded or dizzy, and then 1.5 liters of oral fluid per liter of stool. Obviously, this would best be performed in a clinic since we have the capacity to measure the volume of stool, and we can also perform postural signs. If you wish to buy a brand name, we've all heard of Pedialyte. As an aside, it is quite expensive for your patient population if they purchase it on their own, but if you stock it in your office, it probably would get covered by insurance. When you compare this with Gatorade, Pedialyte has more electrolytes and much lower sugars. It is sweetened with sucralose, and as an aside, sucralose, I believe, is the sucrose carbohydrate, and then they throw a chlorine molecule on it, which gives it stimulation of the taste as if it's sweet, but it's not broken down in the small bowel, so it's not absorbed. Sucralose is the sugar Splenda, I believe, the artificial sweetener, and interestingly, that in itself can cause diarrhea, but I suppose it's not nearly as bad of the diarrhea as what the virus is causing. Interestingly, Pedialyte is sold. I was in Las Vegas recently for the annual meetings, and they were selling rehydration tablets for people who had a bit too much to drink the night before. If you do have access to intravenous options, lactated ringers is the recommended substrate because it contains potassium. You want to replace 50% of the loss in the first 60 minutes, and once they're less nauseated and able to drink orally, I would then switch them over to a oral rehydration solution when they're available. In terms of antibiotics, really there's no role whatsoever for viral gastroenteritis, and even if it's bloody diarrhea, it's really quite controversial as to whether or not antibiotics should be used. Even the enteroinvasive organisms are self-limited, and there's concern that you can increase the risk of salmonella carriage in the gallbladder if they have salmonella as the cause of the infectious diarrhea. Currently, there are no specific antiviral drugs available. The role of antidiarrheal agents, I believe that they're safe to use unless you have bloody diarrhea. So loperamide is safe, and I recommend 2 tablets first thing in the waking in the morning, and then 1 tablet after each bowel movement, up to 8 tablets a day for 1 or 2 days. The mechanism of action is that it increases segmental contractions with an anti-secretory effect. I was recently made aware that there is a black box warning in the PDR for loperamide because apparently opiate users recognize that if you take up to 20 or 30 a day, you can get a slight opiate high. There is a little bit of opiate in there, but what they don't realize is it doesn't cross the blood-brain barrier, so it's not a very effective drug to get high on. I personally don't think there's much role for the absorbents such as kaopectate. I would probably rely more on the loperamide. Antiemetics, not too many studies in adults. In the Cochrane Review in the British Medical Journal, they found that if you do wish to use an antiemetic, it usually should be ondansetron orally or intravenously. It can cause some diarrhea based on its serotonin agonism. In terms of diet, I personally would recommend lactose-free diet for 7 days. The reason for that is the virus will kill the enterocytes in the proximal small bowel, which contain the lactase enzyme. So individuals will be relatively lactase deficient for up to 7 days. Eat smaller, bland, low-residue meals. If you want to rehydrate on your own, you can use sports drinks, although, again, it contains a lot of sugar. Saltine crackers, salted broths will also be a good source of rehydration. Broiled starches such as potatoes, noodles, rice, and wheat would be the diet I would place them on. We all speak of the BRAT diet, which is very weak supporting data, but it's easy for patients to remember. I believe that stands for bananas, rice, apples, and tea. In terms of if you wish to read up more on this, here are a few references that might give you more information. And that is my talk. Thank you very much.